welcome to the second part to this meeting. And there's still some people sipping their coffee, but I hope they will come because they otherwise will miss a fantastic presentation. It's an intriguing new field again in cardiology, all that has to do with artificial intelligence, a lot of opportunities. We all want to know more about that and know one who is better placed to teach us about artificial intelligence in cardiology as Bart Bijnen. So I'm very happy, Bart, that you could make it here live. The stage is yours.
Thank you very much for the invitation. So it's my pleasure to talk a little bit about our experience with machine learning, but also what you will see is that machine learning can help in making our task easier. And you see like some of the companies that are represented here also, they have like tools based on machine learning that can make, for example, echo measurements better. But what I'm personally much more interested in is trying to use this for our understanding, because in real clinical practice, these are the questions that we are faced with. And today I'll focus a little bit on cardiomyopathies, but this is quite in general in some ways, where you start to see ventricles with different phenotypes, or in some ways similar phenotypes. So all of these have some kind of hypertrophy, and with some, we know that there's some kind of genetic abnormality, so we know that there's some myosin kind of mutation in this case. But what you will see, for example, is when you look at this heart, it looks actually a little bit worse than that one, and this one in the end proved to be genotype negative. So you have this mixture of genotypes, phenotypes. When does it become important? How do we discriminate it? Can we understand this? And can we then try to draw conclusions from this? And one thing that you also have to keep in mind, and this is sometimes when you just look at the literature, this is sometimes forgotten, but magical parameters don't exist. So whatever you do is you measure one parameter, and you see in the literature, if you measure this, then you can do risk stratification of this patient, or you can make a diagnosis. Of course not. In clinical practice, our diagnosis, our knowledge, risk stratification is based on all the information that we have. So if we also go to new tools, these tools also have to enable the integration of this information. And that's where I think there's a lot of strength of some of the things that we can do. And especially also, I think you learn a lot from things that you do wrongly and things that are strange. These are the things that have to kind of light a lamp and say like, okay, we have to think about it. And this is an interesting study where they looked at problems of misdiagnosis based on imaging in this case. And what you now see is that although there's of course technical factors, so the imaging itself, or a patient is too obese, you don't see it, that obviously plays a role, but what is actually more important, or at least as important, is underinterpretation and incomplete examination. And this is because you start to do an echo, for example, you see, okay, there's hypertrophy, there's a very thick wall, it's a bit asymmetric, hypertrophic cardiomyopathy, that's it. And you don't look at anything else anymore. So you don't start further, and that's, for example, where you look at technician-based imaging that follow a very rigid protocol, very often is better, even if maybe they're not so skilled, as you could say, in interpreting, but at least they make sure the examination is complete. And the other thing is the underinterpretation is very often our brain is extremely good to quickly recognize things. In the end, quickly recognize threats. And you actually use that also in your diagnosis. But the problem is, if you start using that in your diagnosis, you can actually do very strange things. And this is, I think, an interesting study where you see that they showed radiologists images of CT thoraxes where they're actually embedded here a gorilla in these images. So they digitally embedded a gorilla. And then they gave this to the radiologist and say like, look, do lung nodule screening based on this CT. And 80% of the radiologists did not see that there was a gorilla in there. Because of course they're not trained to do that, you don't expect it, they don't look for that. They just try to do pattern recognition in some way to try to find this. Nothing against radiologists in some ways, but cardiologists actually do the same thing. But very interesting is another similar study, what they did here. What you see is these are just chest x-rays, and what they did, they actually removed the clavicula there. So it's a bit difficult to see here in the room, but you see there's no clavicula actually. Again, they gave this to radiologists to interpret and said like, okay, look at the lungs, and the vast majority did not see that there was a clavicula missing. But at the moment that they said, it's like, look, these are chest x-rays from patients that underwent a new therapy, and we want to see if there's something going wrong, suddenly everybody sees that there's a clavicular missing. So it's really with what mindset and which way you start to interpret these images that makes a large difference. And actually, there's some quite interesting studies that when we do decision making, we actually have two ways to decision making. One is pattern recognition, very, very quick. It's based on what we trained for, and this is what we can do very fast. This is actually what, for example, most of the machine learning that Google and Apple and whatever is doing is this. You recognize patterns. But that's when you make these mistakes that if there's something that you weren't trained for, that you're not expecting, you're not finding it. The other one is the elaborate, is reasoned. You're going to say, okay, let's take all the data. Let's look at the thing. Where is a discrepancy? What doesn't fit? That's the reasoned way. Much slower, much more expensive, but in the end, this is where you find, for example, the rare abnormalities. And when we then start to look at the technology that we have at our disposal, and when we look at machine learning, I'm not going to go in detail today because we don't have the time, but when you look at something that they call artificial intelligence, it's a whole family of techniques, of which machine learning is one, but actually when you start to look at other things like speech processing and language interpretation and things like that is part of it, robotics is part of artificial intelligence. And even in the machine learning, we have really different ways of working. And what is actually the most kind of famous or the most common currently, when people talk about artificial intelligence, they very often infer to what's called deep learning, which is actually artificial neural networks. So we really let a computer create a mini brain in some ways, and then train them to do a certain task. And when you look at this, for example, what you see is this is, oh, sorry. And so all of these different techniques is like what you see is that there are different applications, of course, also in imaging or in cardiology in general. Because even when you talk to the patient, if you would record your kind of examination, or you would look at the written reports in the electronic system, so that's where we can use it. We can actually use it to improve image acquisition. You start to see these little handheld echo devices that give a green light if you have a nice apical 4-chamber view and give a red light when you don't. So it's very good for training, for example. Or we have kind of the automated segmentation, the automatic quantification that you see now in the high-end machines. But what I think is the most interesting in some ways is, can it help us to really do this reasoning, to interpret our data, or at least suggest some things that we should be looking at? And as I said before, it's like most of the machine learning that we currently use is this kind of deep learning, and that is what the big companies are using, and that is actually the biggest boom in artificial intelligence. And that actually comes down that we have deep learning algorithms, so we make artificial brains that can really recognize pattern, that can recognize images, that can interpret it. So for example, if you take a picture on your camera and it says, this is your friend, then this is all based on this. And it's actually based on, in the background, what you can see is that you can do labeling of images. You try to recognize different patterns. That's all very interesting, but actually can we use that for diagnostic medicine? And yes, you can. Here is an example of where they used artificial intelligence in order to look at pathological histology. But for fun, in brackets, they compared it actually to training pigeons in order to also recognize the abnormal histologies. And wonder, oh wonder, the pigeons are actually better than Google in order to do it. But why is that? Well, obviously, pigeons have a brain, and have a brain that you can train to do this pattern recognition. And a pigeon brain is still better than the current computers that we have, and it's in some ways we simulate this. Are we going to have boxes of pigeons in our echo lab? Well, it's not likely. And the other thing is also that, of course, this is important, is like, this is this kind of pattern recognition that you do. And so it's extremely important to see what you are trained for in some way. And here is an example. It's actually a very bad study, but it's just indicative. What you will see is they trained these networks in order to recognize COVID X-rays. And what you see is that you really can have a good confidence in order to do it. Well, of course, in the training, but in the unpredicted or in the unseen data, it's not too bad. But if you give this type of images to the algorithm, it says, I'm 100% sure that this is a COVID patient. Now, the question is why? Well, what it is you have a black field with some white spots on a lighter background. Of course, this is this kind of ground glass opacification that you see in an X-ray. So what you do is you recognize patterns and you just know what you learn, and if you don't give it, then of course you can't recognize it. Now, when we start to use this for medicine, of course, we have to be also very, very careful. And so here is a study where they said, like, okay, if you give me echoes, I can recognize which are the hypertrophic cardiomyopathies. And they trained that, and they see, okay, we can recognize hypertrophic cardiomyopathy. But if you then look at the paper, and this is unfortunately done by engineers and not cardiologists, what you see then, they say, okay, these are the normal hearts. But I think every one of you, even the interventional cardiologists, they will be able to see that this is a dilated cardiomyopathy and not a normal heart. So again, they trained for hypertrophic cardiomyopathy, and they forgot that not all the non-hypertrophic cardiomyopathy might be normal. And this is partially, to me, also the art of medicine. The art of medicine is to recognize the abnormality, is to recognize the rare patient, the rare disease, the thing that is strange, because that will trigger further investigation, and these are the patients that are at the highest risk. So we have to be careful when we use this type of technology, and maybe we have to look at also some different approaches. And what I always like is always take a step back and then say, like, okay, actually, how are we doing medicine? How are we doing decision-making? And can we then plug in the tools that we have in order to improve this, rather than saying, I have a tool, let's test it and see what it gives. And you see, for example, when you start thinking about it, how you do it, well, what happens is you have a patient coming to you. What you do is you acquire information, whether that's imaging, talking to them, going to the lab, do an ECG or whatever. And from that information, what you do is you extract features. For example, a QRS width or an ejection fraction or whatever, and that's what you do. And with that, and with all the information, not just one parameter, what you do is you form yourself an idea of this patient, and what you then do is you compare this whole of information with what you know. It can be with guidelines, with a population, with a study. In order to make a diagnosis, you look, is this patient similar to my diseased patients or not? That's also why you get better the more you experience have as a doctor, because you have more reference to compare with. And this is the thing that you actually use. And based on that, you make a decision. So the question is, can we find ways to actually plug into this thing and then try to improve this? And what you actually see is that indeed, especially these measurements, that's easy to do pattern recognition, because recognizing the ejection fraction or doing a segmentation and things like that, that is feasible. You can train that. Doing this comparison and making the decision, that's a little bit more tricky, because that's where, of course, the abnormalities will arise from. And so the way that I think we should try to do this, and this is a thing that you actually can use machine learning for also, is that you really replicate in some ways this way of thinking. So what you do is you take a bunch of patients, you then take all this information, and what you're then going to do is you're going to rank or position these patients depending on this information in such a way that patients that are similar are close together. So that means that, for example, if you have trained on ECGs and echoes, then the ECG and echo of these two patients here will be very similar, but of this patient and that patient will be very different. So you really say you take each patient and you put them in a distance depending on how different the information is. And what you then can start to do is, of course, when you do this in a larger population, you see that patients with similar features probably have a similar diagnosis, because that's actually how we make the diagnosis also in some ways. And then, of course, if we have knowledge, and this happens without any knowledge of outcome, but if we have knowledge of outcome, what we, of course, can do is put risk assessment based on that. Or if we have trials that says in this patient group, this therapy works, then we can actually base therapy suggestions on this. And so, if you do this during the learning phase, what you then can do with a new patient is saying, a patient comes, we do the measurements, and we're going to see where is this patient located in this whole population. And based on this now, what you can say is, by the fact that a patient is close to some, what we can do is we can get a diagnosis, potentially a risk prediction or a therapy suggestion. But the other thing that we can also do is, of course, do temporal follow-up. Because if we acquire data, and a patient was here, for example, say that these are the dilated cardiomyopathies and these would be the normal ones, if we do treatment, what we hope is that the information of that patient would move towards normality rather than towards further abnormality. So you can even do temporal assessment or therapy prediction or follow-up based on this. And then I'm trying to advance the slide. Yeah, okay, here we are. So, and the other thing that you can do, as I said before, is you can actually integrate information. You don't have to do this based on one parameter. Right? I mean, our brain, and as a human, what we try to do is very often is try to simplify it. But the machine is smart enough that we can really use all this information. And another thing which is also quite useful is that we can use complex information, so whole traces over the cardiac cycle, whole ECGs, all the ECG leads at the same time, rather than using singular measurements on these ECGs. And so let me show you a couple of studies in order to illustrate this. It's preliminary, it's just some starting work. And what we did here is we looked at hypertrophic cardiomyopathy patients where we knew the genotype. So these are clinically diagnosed hypertrophic cardiomyopathies, with many of them genotype positive, other ones that we don't know. And if you then position patients, in this case based on the echo information, where we use the strains, we use the envelopes of the filling patterns, and we use some clinical information, what you start to see there is that hypertrophic cardiomyopathy patients cluster together, but not all of them. And this is also a thing that we know. Patients are a spectrum. They're not black and white. And what you then can do is, the nice thing is that you can also investigate this and see what is different. Why does the computer think that these patients are different from these? And then you can see, of course, obviously, when you look at the aorta, an outflow tract obstruction is something typical for the HOCM patients. But what you also see is, of course, you start to see diastolic dysfunction, you start to see atrial dysfunction, and you start to see sometimes segmental dysfunction. And you can then actually compare also these patients, and you can see that there are significant differences in these. But of course, what we now also can do is, for example, put the relatives of these patients together, because we do family screening when we do that. And what you then see is that some relatives are indeed close to the patients, but other relatives are far away from these patients. Or what we can do is also compare to healthy controls, and then you see that these family members that are clinically healthy, many of them are not that healthy when you look at the data, or at least their data is different. Whether that's healthy or not, that's of course something different, but at least the data is different. And then you can say, like, okay, but when we look at hypertrophy, hypertrophic cardiomyopathy is one thing, but extreme hypertension is of course phenotypically similar in some ways. And then you see that indeed there is some overlap, but on the other hand, there's also some non-overlap. And even also the hypertensives, these are clinically treated hypertensives. So they should be all normal. And then we see also, like, okay, a majority is normal, but and there's also a bunch that is not abnormal. So maybe they're undertreated or something else is going on. So these are the things that we can look at, and we can then really look at the different types of remodeling. Now, here is another study. It's like a follow-up in some ways, looking at this in the hypertensive cardiomyopathy. This is a study that we're also going to continue together here with the Antwerp team. And what we looked here is, again, at hypertrophic cardiomyopathies and the different risks, and that we then try to see and associate this with risk. And for example, an interesting thing here is that you see that the hypertrophic cardiomyopathies, many of them are located here, a whole bunch of them. And if then, for example, we look at the late gadolinium enhancement independently of this, then we see that actually late gadolinium enhancement is more prevalent in these ones. And of course, if we overlap these, you see that it really overlaps. So you see that late gadolinium enhancement as an independent measure in some ways is correlated to some of the echo measurements, but not necessarily, not in all of them. So you see that it's complementary information and not very similar information. And then you can see, you can do like different ones and then try to recognize which are, for example, the highest risk patients. And what you now can do is, of course, we have these individual patients, these 4 patients that I showed you in the beginning. Where are they located? And can we then look, for example, at some of these? And you really see then that you go from kind of even genotype positive one, but it's located close to the normals, versus some, here this one is, for example, from an unknown genotype, so the panel was negative, but when you look at it, everything outflow tract obstruction, and we actually had tissue from them, so with immense fiber disarray, so it's clearly that this is some hypertrophic cardiomyopathy remodeling. And here, this way also, it can help. It is additional information in some ways to the genotypes. We can look in these patients also at the ECGs, and you can do similar things with the ECGs. This is just some preliminary results. I'm not going to go in detail, but I'm going to show you how we can look at ECGs in a different way. So what we do is we take the 12-lead ECGs, What we then do is we actually use deep learning, so machine learning for segmentation. So we train the algorithm to recognize the different kind of periods in the ECG. What we then do is we try to now look at these shapes of these ECGs and then try to see whether we can position patients based on the whole shape of the ECG. We don't do one measurement, not QT duration or QRS or whatever, but what we do is we look at the whole trace, we position them, and what you now start to see is that you see really different groups with different risks. And you see that the ECGs, for example, in the obstructive cardiomyopathies are different from the non-obstructive, but all of these are high risk. And that's what we see. But then on the other hand, there's also a high-risk group, which is very different from there. And these are the ones that actually show much more arrhythmias. And so this way, what we can try to do is we know that the HOCM population, when we look at the phenotypes, is very diverse. And we also know that there's not one risk or one type of things that give risk. Or for example, when we looked at this morning about the Brugada patients, we really have different etiologies in some ways that can lead to problems. And this way we can try to discriminate these. And then also for the electrophysiologist, you can really explain or at least show what is different in these ECGs in these different groups. And this can actually be hypothesis generating in some ways also. To finalize also, and especially for the echo people, that we can really learn from this, here is an example of a group of dilated cardiomyopathy patients that we looked at. And this is a high-risk population where about 50% either dies or need a heart transplant. And we're going to try to see whether based on the Doppler flow data, but the whole profiles together, so aorta, mitral, pulmonary vein, together with the regional strains, whether we can try to predict who are at high risk and also see why they are at high risk. And so we do something similar. We position the patients based on these signals, and what you then really see is that there's a clustering of the high-risk patients and that you can really identify in some ways these. But what to me is more interesting is that you try to see is when you group these patients in like different clusters, and we know the risk. So you see, for example, this red cluster has an extremely high risk for death or transplant. And what is different? Can we understand this? And then just very, very briefly, what you see is if you look at the outflow and inflow pattern, what you see, for example, you have a very long isovolumic contraction time. You have a very late peaking of the aorta, which we know that is related to myocardial dysfunction. We see kind of fusion. And what we see is also we see a very, very delayed reversal in the pulmonary vein. But what you don't see, and what you would expect in this population, is you don't see any restrictive filling. But when you start thinking and you start looking at the literature, then you see it's like the pediatric cardiologists, they're always complaining that adult guidelines don't work. And actually that's the case. Kids will almost never show restrictive flow patterns, even if you see here that they have enormous atrial pressures. That's of course because their relaxation, their intrinsic relaxation is almost always preserved. It's very rarely that it's not. So this can help us also to identify why these things are happening, for example. Similarly, when we look at strain, a lot of people say like, oh no, global strain, that's the answer to everything, and this is going to be our risk. But what you see here is that our highest risk doesn't have the lowest strain of all. And other ones which have very low strain, here for example this yellow one has very low strains in some ways, but has preserved apical strain, and they actually don't show events of heart failure or death. So you really see that some of these things are much more complex, and that by trying to figure out the underlying mechanics and etiology, we can actually see much more. And what you then see is that you really start to find these things. And one thing also that you see from this, and that's another thing that many of these people that are doing these studies don't think about, is that actually in this population you actually have two peaks. You have very early deaths in the very, very young infants, and then you have later ones in the 10 years old, 15 years old, and almost nothing in between. And they seem to be different also. So again, pooling these patients which are intrinsically different in the etiologies might be not the best way of doing. So what I wanted to show you in this very brief and maybe rather intense presentation is that what you really need to do is when you use some of these tools is like go back and how do you make decisions? How can it help in order to look at this? And we can actually use this technology not only in order to make our lives easier, and that's what you see that the companies are trying to do with putting machine learning in the machines to make it faster and better, but we can really try to do this in order to get a better understanding in our patients, and especially going away away from this cutoff of dichotomy. It's like, it's either that or that, and that is high risk, that is not high risk. No, life is much more complex. There are different groups. There's a whole kind of transition. There's no different kind of cutoffs in some ways. And this we can really understand and see what is the important information we have to look at, how can we use this, and this way I think we can really go much closer to personalized medicine. Thank you very much.
Thank you very much, Bart. Very inspirational talk. One question, if there's no question from the audience, is that we have the impression maybe that this sort of AI work is the work for the big centers because they have the biggest data sets. And I have two questions related to that. Is that true or not? Can smaller centers also do good AI-based work? And second, if you have AI-derived sort of classification from a big data set in center A, in how far can the results of that be applied to a data set in a center B?
Yeah. So the first question I want to answer with something that everybody knows. Do you use ejection fraction to make a decision, only ejection fraction to make a decision in a single patient that in front of you? You have a patient, 40% ejection fraction, what are you going to do?
Depends on what is the question.
Exactly. So while when you look at big data, they showed that ejection fraction with a cutoff of 50% is the thing that you need to make the decision on, which of course is not true anymore in the individual patients. So here also, just like ejection fraction, whatever we find now with big data is you find patterns in there, and they use also this kind of deep learning. So you get information, you get parameters that are quite interesting on the population level, but not necessarily very interesting on the individual level. We still can use what they find in order to help us in some ways to stratify. I mean, ejection fraction, I think, is not very useful in the individual patient, but you're still going to measure it and at least keep it in mind as one of the parameters. That's the same thing with these big data sets. And of course, only if you have these big data sets, you can find this. Ejection fraction was also defined in these large studies with thousands of patients, not in the individual ones. But what I showed you in the last part, this, for example, this pediatric dilated cardiomyopathy, this is just 50 patients. And you can really extract a lot of information, but you need to use different tools. And if you want to go to try to much more understanding of the individual patients, then you don't need 10,000 patients. And then you don't need this type of technology. Again, if you want to do automated segmentation of an echo or something like that, then of course you need that for the training, but it depends on what kind of tools you have. And I think the smart work is done in small groups of patients to start with, and then of course you have to test that in other patients. So AI is very diverse, and it depends on what you want to do and what you want to study.
Very good answer. Okay, then for the sake of time, Bart, we will move on. Thank you very, very much.